to start documenting this and turn this into the owner of the imaging center, because you're looking at a huge malpractice. When you're telling somebody, you just paid $8,000 for a PET scan, and they're anywhere from $8,000 to $12,000, and you're telling them it's normal. So you think, oh my God, I'm so thankful because I was really feeling horrible, but now I know I'm not feeling horrible because of the cancer that was diagnosed. I'm well. So it must be something else. I would be really upset as a patient. Okay, but anyway, so alignment, very important. Making sure that you're looking at the same part of the heart for both of the studies. Then this other thing here is the count rate. Remember I told you, if your first dose is 10 millicuries and then your second dose is 25 to 30 millicuries, then when you do a composite image, when you compare the number of counts that are in both of these, if this is my stress and I did that with 10 millicuries, and here's my rest with 25, or if I did it vice versa, then this one should have 2.5 to 3 times more counts per pixel for the same area, unless they got really bad perfusion. But even if they do have really bad perfusion, they should still have at least that ratio of counts. Does that make sense?
Yes.
Okay, if it doesn't, then you better check the arm and make sure your dose didn't infiltrate. Okay. The other thing, normalization. To understand what normalization means is if you were to take the rest picture here that has 10 millicuries and compare it to the stress with 30 millicuries, this one would be 3 times brighter, wouldn't it? Because of the counts. Normalization adjusts the display intensities so that they look the same. That's all normalization means. And that's why you've got to be very careful, because if the computer selects an area like, in the gut or in the liver, and it thinks that's the heart, then it's going to adjust or normalize the images to that. So you may actually have a situation where there will not be any activity in one of your images because it saw the activity in the gut and says, oh, okay, well, when I try to normalize it to the other picture that John took, there's nothing there, comparatively. Does that make sense?
Yeah.
Okay. And then the extracardiac activity we already talked about. Okay. But like I said, when a computer is normalizing something, it's going to search out the highest activity. And if the highest activity happens to be here in the intestines, then you're going to have some interesting images. Okay? This is in the handout that I gave you for SPECT quality control. Okay, we already talked about that. Okay. This test that I didn't send you the answers to, this is more, let me go back to the computer here for a minute. Okay, this is more of like an anatomy type of a thing where after I made up this handout, this was in what I call the before time. As I got more creative in my questions here, let me just go to questions.
Nice speech. But the test that you send the answer start with question 37.
This one?
Yes. You didn't have from 1 to 36.
How far did you go through? Let me see what we got here.
100. There you go.
That's weird. So the first page of answers isn't working.
Yes.
Okay, I'll see if I can find that. But on this one here, the questions, as I got more sophisticated, this is a test Okay, this is number 32 here. Okay, the QP to QS ratio, remember we said that if you have a ratio of 1.0, what does that mean? Do we have a shunt or no shunt? Okay, there's no shunt. It means that the amount of blood coming into the heart equals the amount of blood going out to the body. So the QP-QS ratio is 1. Okay? Yeah. 1 means that there's no shunt. Anything normally higher than like 1.5, if you have a 1.5 ratio, then that means that you have a shunt. Okay? And then, you know, some of the other things, okay, like on this one here, what's John, or what's Mr. Radke doing to you here? What are we evaluating here?
The time of the injection. The length of the injection.
Okay, well, so what I have here, this is where this histogram came from. This is a histogram, remember it's a count versus time activity curve. So we have radioactivity coming in from what blood vessel is this? More than likely. No, it's got to be over here somewhere. Remember, when you inject into a patient, what veins are you injecting in the arm?
The cephalic thing.
Either the cephalic or the okay, medium cuboidal or the basilic. Okay, so normally, you know, remember we said the cephalic kind of goes all over the place. The basilic is the best one to inject a bolus in. But most of us wind up using the antecubital because it's the easiest to locate. So basically, from there it forms the axillary vein. This is the subclavian. And it goes into where?
Superior vena cava.
All right, superior vena cava. So this is where the region of interest is. Okay? So if I'm putting a region of interest here for that, then what am I evaluating?
How long it took to get there?
Well, I'm evaluating the quality of my bolus. Okay? So on question 31, we're evaluating the quality of the bolus and full width half max. So on this thing here, 30,000. Okay, so we have one at about 0.75 and 2.75. So what's the approximate bolus injection? 2 seconds. Is that good or bad?
Bad.
It's a little bit too long, isn't it?
It's optimal again?
Less than 1.
About 1.5 or less. Okay. And then the next one that I have up above here. Okay, we like to do, well, when we're doing right to left shunts, the radiopharmaceutical that's often used is technetium MAA, right? Okay, now that's another thing that you need to be aware of. Okay? If we're doing QP-QS ratios, we need to have a large quantity of radioactivity that's, when it's injected, it can go through the heart and lungs and recirculate. Okay? So I cannot use MAA for that. Okay? If I'm looking for left to right shunts, I need to have something that goes through and comes back to the heart. Okay? I can't do that with MAA. Right, because when I inject MAA, it gets trapped in the capillaries of the lungs and it doesn't recirculate. Only time that it gets out into the systemic circulation is if there is a right to left shunt. So we only use MAA for right to left shunts.
Use for left to right?
That could be like technetium by itself, or we can use DTPA, or we can use any radiopharmaceutical that just, you know, we're able to inject in a large quantity and not, you know, have to worry about, you know, it's going to some other organ or something. Okay. A lot of times people will use DTPA or just protected tape by itself. But on this one here, so using MAA, okay, so the complication of using MAA, which is why you have to keep the number of particles down, is because of C, embolization of other organs. You know, so you're talking about going to the capillaries of the brain, capillaries of the liver, capillaries of, well, the liver we're not too worried about, but kidneys. And then the number of particles, okay, normally we keep it about 100,000. So that's why when you were learning how to calculate the number of particles per ml, you have to have that combination of a large amount of radioactivity with a small number of particles, or you have a problem. Okay, and it says which type of shunt is being quantified with MAA. Okay, you can only do right to left. Okay. Remember that if I was doing a lung scan, a patient with a shunt would be something that would, you know, make me be careful, right? Remember we said that any time we do a lung scan for a pulmonary embolus, we have to be careful of pulmonary hypertension and shunts. Okay, so we have to be careful how many particles we injected. So the only type of shunt that it will identify is a right to left shunt. Okay. And this is the formula here: the total body counts minus the total lung counts. Okay. Now the total body counts, that includes both the lungs and the body. Then minus the lung counts divided by that. That's your formula for calculating shunt quantification.
Which one?
This one here for 29.
Right or left?
No, this one here for number 28, it's only going to be right to left shunt for this one. Okay? So letter C, this is the formula that you would use. Do you think you might see one of those on your test? Yeah, probably. Okay, so let's see what else we have here. Okay, this is another thing here. On this type of a thing here, this is using a radiopharmaceutical, and what you're doing is you're drawing a region of interest over the right ventricle and one over the left ventricle. Okay? Everyone okay on that? When I inject the radiopharmaceutical, let me just, when I was trying to get stuff out of my car, or in my car, tweaked my back. Ooh. Okay, what we're doing on this, okay, remember before I showed you we have the radioactivity coming in, kind of goes into the right. We have the subclavian up here, we have superior vena cava, we have the right ventricle, and it goes out to the lungs. Okay, and then it comes back and it goes into the left ventricle. Okay. This is kind of like a first pass study type of analysis. And what you're going to do is, okay, you have a region of interest up here. So there's ROI1, and that's so that you can, you know, make sure you got a good bolus. And then you draw a region of interest over the right ventricle. So there's ROI2, and then one over the left ventricle, which is ROI3. And basically, what we expect to see is, okay, we know the radioactivity comes in, it goes into the right side of the heart, it goes out to the lungs, comes back to the left side of the heart, and then it goes out to the aorta. Okay, that's the sequence. So if I drew regions of interest on that, then what I would expect to see, okay, here's the right ventricle coming in, okay, it gets pumped out, and then later on I would see a recirculation curve if I was just looking at the right ventricle. Agreed? Then with the left ventricle, my region of interest, I shouldn't see any activity in my left. I shouldn't see any activity in the left ventricle until after the blood has been pumped out. Okay, then I might see a rise here, and then, you know, recirculation curve. So if I happen to see a shunt, okay, for example, if I see a rise in activity here in the left ventricle at the same time that the activity is being pumped out of the right ventricle, that means that there's activity being pumped through the shunt into the other ventricle.
Right to left.
Yeah, so this would be a right to left. If I saw the activity over here, okay, let's say that this, I actually kind of didn't draw this correctly here, but let's say that I see a blip over here. Okay, this should be, this is left ventricle here. If I see left ventricle and then all of a sudden activity is being pumped back into the right ventricle, that's my left to right shunt. Okay, so in the example that I gave you here on the computer, for question 25, okay, what type of a shunt is that?
Right to left.
It's a right to left shunt, yeah, because you see here's the activity in the right ventricle. There shouldn't be anything in the left ventricle at this time. Okay. Yay! You guys will be doctors by the time I get through with you. Huh. Okay, I think on this, one of the other things you guys should be aware of are the blood tests that we use. All of these are tests that we use to determine if you've had a heart attack, but also remember troponin. Okay, troponin. Troponin is also one of the ones that are there. Okay, let's see. In this one here, the different views that we would take. Everyone familiar with the Bruce protocol? Okay, 220 minus your age, minus 0.85.
For wrestling.
For that's the maximum. That's 85% of your maximum predicted heart rate that you have to obtain in order to do a satisfactory stress imaging. Okay. You know all. Okay, we know persantine, we know adenosine, and we know lexiscan. Right? Remember that persantine releases adenosine. Okay? But you have to wait 5 minutes after you've injected the persantine before that happens. Does anybody use persantine? I don't think anybody does. Okay, because with persantine, you know, you had to wait 5 minutes, and that would release the adenosine. We knew that the adenosine was working because what happened to the blood pressure and what happened to the heart rate?
Blood pressure goes down 10, heart rate goes up 10.
Right, blood pressure goes down 10 systolic, heart rate goes up 10. Okay, and that's when you inject your radiopharmaceutical. Okay. So what else? Okay, the other thing is you need to know what drugs do we give, or how do we, you know, if a patient has persantine, then because it has a longer action, you normally have to wind up giving one drug, what drug to stop the action of it? Okay, heminophilin. Okay, normally it's a 250 milligram per ml vial that you have. So for adenosine or for persantine, you would use that. You could also use it for lexiscan too, but remember that normally what do you do for adenosine to stop the reaction or the problem? Okay. Yeah, you just stop the flow, because remember it has a short half-life of only about 15 seconds, 10 to 15 seconds. Okay, so normally just doing that. Now, what's the advantage of lexiscan over adenosine?
The least amount of side effects.
Huh?
Least amount of side effects. You know,
Activates only the A1 receptors in the coronary arteries.
Yeah, the adenosine affects all of the receptors in blood vessels and causes all of them to dilate. Okay, lexiscan affects only A2 receptors in the coronary arteries. So hopefully those are the only ones that dilate. Okay, so it's very expensive, but it's one of the ones that are fairly important. Okay, I think probably
That's it.
you notice that I've got different symptoms on here. You might want to take a look at those when you're doing that. Trying to think what else we have in here that would be important. I think I've got some MUGA study stuff in here that I want to make sure you guys are okay. Oh, on number 59 here, hopefully, do you guys feel comfortable calculating doses for your patients? The patient weighs 250 pounds and you're going to be administering Prasantine. And this is the actual rate of administration. But this is true for any of our drugs, whether you're using dobutamine or Prasantine or whatever. We base it on the patient's body weight. Okay? So if you're going to be giving 0.56 milligrams per kilogram, how would you calculate how much dose this patient should receive?
220 pounds is 100 kilogram. Then you time with that.
Okay. Well, what I was hoping for is that, yeah, you would first of all need to say that you need to convert pounds to kilograms. 2.2 pounds equals 1 kilogram, so that 100 kilograms. So 100 kilograms times 0.56, so 56 milligrams.
Yeah.
Okay, and that's true any dose you're calculating. On this one here, which radionuclide for myocardial quantification allows you to measure the percent washout between stress and rest phases? Yeah, thallium is the only one that washes in and washes out. Because remember, sestamib, once it gets trapped in the myocardium, it doesn't leave. So you're looking at the picture of the heart at that particular moment of time. It's not a dynamic type of a study. Okay, let me see if there's some other fun things in here. I put some drugs in here. Now, there's also a section that I sent you on drugs. Okay, it covers the basic ones that we use. It's chapter 25. Okay, it's in the stuff that I sent you. It's only a couple of pages, but it's got a couple of important things in there. Okay, but anyway, so like a patient, okay, when you're having, we already talked about this, which medication blocks adenosine receptors and is the antidote for Prasantine and adenosine. Okay, remember that's aminophylline. Okay. I also have a question up here about recognizing patterns. Now, in the test that I'm going to give you, I'll probably have, I'm going to try to get regular images and include those. Okay. So you're going to get a question that's not only going to ask you, say there's a perfusion defect on the inferior wall of both the stress and rest images, so that means the patient has what? Okay, it's an infarction, it's a myocardial infarction. Now, I'm going to give you a picture that shows maybe, decreased flow on the stress and normal flow on the rest. So you're not only going to have to tell me what the diagnosis is, but you're going to have to tell me what part of the heart is being affected. So is it the septum? Is it the anterior wall? Is it the lateral wall? Okay. Sound like fun? Okay.
You're going to use up our weekend.
Yeah, class is over.
I know, but I love you guys. I want to make sure that you guys don't have any problems with these.
You see everybody face
Okay.
like...
Okay. Number 8, you guys tell me what number 80 would be, what drug is, if you're using dobutamine, what test or what drug would interfere with it?
Beta blockers.
Yes, beta blockers. Okay, because that lowers your heart rate. And dobutamine is vasopressor. Okay, so anyway, you have a pretty good idea of what to expect.
Just
And-
next week.
Yeah.
So just study this 100 question, you
So you
give
said
it.
for, can you go up again?
Do what?
Right there. So you said for 83, either prone or,
Yeah. If you have remember the two defects that we were looking at, we had diaphragm attenuation and breast attenuation. And usually lying prone eliminates that. What actually happens is that the abdominal contents push the diaphragm down.
But
Okay,
could
so-
you do it with just C and then it'll just outline the injured area?
Well, remember, if the patient had the heart attack, you know, last month.
D.
Yeah.
Every
So it'd be
boy is D.
is it A? It's A, right?
well, see, women with large breasts, okay, the best one for arrest would be sestamibie. We don't like thallium on big patients because of what?
So hard to
Low
As a
attenuation.
wash.
The energy. Yeah, remember, what's the energy? It's mercury X-rays. 67 keV. What do you think is going to go through a lot of tissue? 67 keV or 140 keV? 140, yeah. Sound like fun, huh?
You really use up our weekend, huh?
Well, let's see. So did you guys get any vacation for spring break? I guess the break, that was your spring break. Huh?
I did. We went on a cruise.
Huh? You went on a cruise?
Yes.
Whoa. Man. Okay, so next week, you guys quiz over the heart.